about anesthesia, I do want to direct your attention to the memory jogger on page 223. It says 2 common antidepressants used for pain management are gabapentin and pregabalin. These are not antidepressants, they're anticonvulsants. So if your book says antidepressants, that's a misprint, and you want to change that to anticonvulsants. All right, now, our old book used to have a little section on anesthesia drugs, and this book does not, but I think it's valuable to know something about some of the drugs our patients might get. You know, we think of them as you get a mask put over your face, you inhale it, it puts you to sleep, and then you wake up after the surgery. But there are a lot of meds that are given for anesthesia, and they are for a number of different reasons. So this is not covered in your book, so any test questions you have are going to come from this PowerPoint and my lecture. So some different types of anesthesia that you might be familiar with. General anesthesia, and in this case, this is where they call being put to sleep. So your body is non-responsive, hopefully. You are unconscious. So they'll give you IV medication or gas or a combination of the two. But they're also going to give you a sedative to keep you in a deep sleep, and many times a paralytic agent, because they don't want you jumping around during the surgery. Think about when you're falling asleep. We've all had the experience probably of, you know, you're dozing off, you're about half asleep, and all of a sudden you have a sensation of falling and you jump in your bed, or in my case, in an airplane seat, jostling the poor guy next to me. These are used for more major surgeries. They're also used for pediatric surgeries like tonsil removal, because you really, really don't want a child awake. You want them knocked out. Then we have regional anesthetic. This numbs a part of the body for surgery. So it's often used during childbirth or procedures where you only need parts of the body numbed. Like they can do a arthroscopic knee surgery and just numb your legs. So you might get a spinal block, which is a little bit deeper and stronger, or you might get medication in the epidural space outside of the spinal cord. Now, for spinal anesthetic, you're going to have 3 major side effects that need to be watched out for. It can drop your blood pressure. Many times the bladder is the last thing to gain feeling again, and so the person might have urinary retention that could lead to discomfort and infection. And you might end up with a spinal headache if there's a little leak in the covering of the spinal cord and cerebral spinal fluid leaks out. You can get just what I'm told is a terrible, terrible headache. And then we have local anesthetic. That's a topical med or just an intradermal injection of a numbing agent to numb a small area, maybe before you have a mole taken off to be biopsied, or a dental procedure. They're going to fill your tooth. You don't want them drilling without any kind of anesthesia. Most people don't anyway. And so they're going to inject a local anesthetic. So here we see what it looks like in the OR with a general anesthetic. The person is unconscious. You can see that there is a anesthesiologist probably and an anesthetist. Sometimes the anesthetist is there monitoring vital signs and making sure that everything's okay with the patient while the anesthesiologist is administering the medication. And this person is put out. Regional anesthesia. This looks like an epidural. And usually the person lies on their side with their arms and legs kind of drawn up so that their back is a little bit bowed. That opens the spaces between the vertebra. Sometimes the patient sits up and leans over. And that is just going to, depending on where it's put, what level it's put, it's going to numb a certain part of the body for surgeries or for childbirth. And then local anesthesia. Here we see a dental hygienist or assistant injecting Novocaine so that a person can have their teeth worked on. So in addition to the meds to put somebody to sleep, there are a lot of other meds given with anesthetics. We're going to give anticholinergic agents such as atropine to dry up respiratory secretions. We're going to give cholinergic agents. Remember, anticholinergic agents are going to dry up urine, but cholinergic agents are going to encourage successful urination. So many times they'll give a drug to try to encourage the nerves and muscles of the bladder to be able to function properly so the person can drain their bladder. Many times opioids are going to be given, even though the person is asleep. You can still have a sensation of pain while sleeping, so they'll give opioids to relieve pain. Neuromuscular blockers to paralyze the muscles so that you don't have certain parts of your body twitching. You also, if they're doing an abdominal surgery, they don't want the peristalsis to be going along. They don't want that GI tract doing those involuntary movements. They want it quiet so they can do what they need to do. They'll give pre-op medications, usually in the pre-op area before you even get into the OR. And that'll relax you to make induction of anesthesia easier. Usually before a surgery, you're pretty nervous, or you ought to be. And you've got the sympathetic nervous system going. You've got that fight or flight reaction pouring in epinephrine and norepinephrine, making you nervous. And so if they can relax the patient with barbiturates or benzodiazepines, many times that will help them to calm down a little bit so that they don't have that fight or flight reaction. Doctors might give dopamine blockers such as promethazine, Phenergan, to relax and also to prevent nausea and vomiting. And sometimes they'll give GI meds to decrease acid or to speed gastric emptying. One of the first things we would do when I worked in labor and delivery, as soon as you knew that they would be calling a C-section, was you'd go to the Acudose and you'd get 20 of Pepsid and 10 of Reglan. So the Pepsid would decrease the production of acid, and the Reglan would speed gastric emptying so things wouldn't slow down and you wouldn't end up with a lot of GI problems and nausea and vomiting after surgery. And many times, as a nurse, you kind of get that feeling, this labor has been going on for a long, long time, and we might end up having to do a C-section for failure to progress. I'm just going to go ahead and pull those meds. Just keeping them nearby, so I'd have them to give right away, knowing that they could be returned if it turned out that it wasn't needed. So that is it for this chapter, and make sure you read and take notes in the PowerPoint.